This is episode 5 of the webinar Surgeon's Log 2020. It is morning in the United States, so good morning to our US viewers, and welcome to all international viewers from across the world. I think we are good for time zones all the way from the Western Hemisphere to Asia and across Europe and so on. So welcome everybody for joining us. Today we have a very fabulous panel of experts to give you the webinar. I am your host, Walter Jean from George Washington University, and behind the switches are Dr. Michael Wong from UCSF. So just to introduce, I'm going to go ahead and share my slides so I can introduce the speakers. Okay. So our special guests today are these gentlemen, master neurosurgeons, both of them. Dr. Diego Mendez Rosito is the director of the skull-base program at the Centro Médico 20 de Noviembre in Ciudad de Mexico, and Professor Doo-Sik Kong from the Samson, I misspelled them, Medical Center in South Korea. As I said, both of them experts in their countries and in their fields. And on the hot seat today is Kunal Vakharia. Second Kunal in 5 episodes. Every time I have a different difficult time pronouncing the last name. And Kunal is going to be our hot seat resident. Hopefully he can verbalize what the audience is thinking about the case. So let's get going. And here is Le Faux Miroir. So, by the way, Le Faux Miroir is this René Magritte's masterpiece from 1928 that hangs in the MoMA in New York City. And it is, of course, of the eye. So, Kunal, you have a 55-year-old previously healthy woman as a patient walks in to see you. She's complaining of 8 months, starting 8 months ago, she started having some pain in the forehead region. And this was at first controlled with painkillers over the counter. But 5 months ago or so, she started getting having trouble seeing out of the left eye, accompanying this pain. So your neurological exam shows that she is in fact blind in that left eye, and there's absolutely absent pupillary reflex, but a concentric reflex on that side, so a gun pupil. And she has hypothesia on the left side of V1 and V2 with normal eye movements. The rest of the neurological exam is normal. So very simple first question, where do you think the localization of the problem is?
So she's got compression of both the optic nerve as well as potentially the trigeminal nerve. This could span along probably segments from Meckel's cave, cavernous sinus, orbital apex in that area. That's probably where I'd localize this, at least based on those 2 nerves.
So what would you do next? Very simple question.
So how long have her symptoms been going on?
8 months.
8 months, and they've been progressive over this time?
Yes.
So the fact that she's completely blind now, and I'm assuming her ocular motility is okay.
Normal eye movements.
So I would obviously scan her head, start with a CT scan and an MRI. So here we have axial T1 weighted contrasted scans showing what appears to be a cystic, multicystic, heterogeneous enhancing tumor that goes actually through the orbital apex with compression of the optic nerve. It looks like it's both. So my thought process when I'm looking at this initially is determining whether or not this is entirely, well, it's not entirely intraconal. It looks like it goes within the muscle, so and then extends intracanalicular all the way along the wall of the cavernous sinus on the left-sided image.
Now, is it intracanalicular as opposed, by that definition, you're going in through the optic foramen? You think this is going through the optic canal, or do you think it's going through some other space?
Ideally, I would get a coronal as well and a sagittal and look at it on multiple planes, but my thought process, okay.
And mind you, her first symptom was the pain on the face, right? And then the eye issue followed 3 months hence. So does that give
So
you a sense where?
given that history, I would think supraorbital fissure.
Okay.
But at the same time, it looks like on the initial axial image with contrast, the optic nerve is entirely pushed medially. I'm not sure if there's another component I might be missing, but supraorbital fissure based on the history.
All right. So yeah, I think you. So what is it? Animal,
Uh,
vegetable, or mineral?
I mean, the differential includes schwannoma, potentially if there's remodeled bone, talking about potentially a meningioma with microcystic components or a meningothelial type meningioma. But given the history, the progressive nature, and the microcystic appearance, schwannoma is probably on the top of my differential.
And there could be some bizarre tumors in this area too, right? Metastases can sometimes do something bizarre like this, and other very, very rare sort of entities. So what's next? I mean, do you need any more testing? Do you need what's next?
So I don't think this necessarily has any impact on endocrinologic function or anything along those lines. I don't think you need any other testing from that standpoint. But in all fairness, I probably would get a formal ophthalmologic evaluation,
Okay.
and probably also get an idea with an OCT of what the back of the eye looks like and whether or not there's any chance of recovery, especially since this has been happening over 8 months.
Right. So Diego, I didn't see any CT scans that you submitted, but I would actually agree that a CT scan might be very interesting to look at the bone remodeling. Was that information available?
Yes, definitely. The CT scan is very important, and there was some erosion in the like thinness of the superior orbitary fissure.
Superior orbital fissure. Okay.
Yeah.
So what else are you going to pay attention to restudying the scans, Kunal? You've already mentioned some things.
Okay, so looking at the scans again, I would probably pay attention to where my carotid is in relation, whether or not I'm assuming it's more pushed medial than anything else, and understanding my vascular structures from that standpoint. If I can, seeing where
What
my
else?
artery is in relation to the tumor, especially the portion that goes closer to the optic nerve through the fissure. I don't know. I don't anticipate being anywhere close to it based on the fact that it's going through the supraorbital fissure. Obviously, the optic nerve is key.
Yeah, so I always advise my trainees when we look at something like that to really pay attention to what can really make your day a bad one when you operate on this, right? And the two things really is the optic nerve and the carotid artery, which you've already mentioned. And that also therefore that also gives you the information as how you would design an operation around these sort of structures. So you basically said. So what's the goal here? Are you going to say we're going to do something for you, or are you going to say okay, bye bye, good luck to you? What's your goal of treatment, if any?
So I think, I mean, there are really three basic options. One is surgical intervention, radiation therapy, and conservative therapy or doing nothing. I don't think the last two are really options in this situation based on the fact that this has been a progressive problem. It suggests that this is something that's growing and causing more compression on the outer layers of the optic nerve as well if she's had progressive blindness. So I would argue that this is probably growing, and I would argue that this needs treatment. From that standpoint,
What's your goal of the treatment? Is the goal of treatment just diagnose and adios, or is the goal of treatment more than that?
so I don't know enough about the likelihood that she's going to recover function of the optic nerve. I don't think it's just diagnose and get out. I think it's probably going to be a resection as safely as I can without getting too close to the optic nerve. I think leaving a little residual may be okay in this situation, because I'm not sure how much of the optic nerve or her vision I'll be able to regain.
So you want to decompress the orbit so that, at least this thing doesn't get any bigger and then cause a problem more than blindness, for example, pain, if you have a proptosis bulging the eyeball out, right? So decompression, would that be fair?
Yeah.
All right. So the $1 million question now, what are you going to tell her about the risk and how you're going to do this?
So she, for good or bad, she already is blind and has already lost vision there. So the biggest thing from my standpoint is tell her that the risks associated with having any worsening vision or worsening paresthesias or kind of a neuropathic pain is relatively small. She's already got a neuropathic pain. I could potentially convert that to a neuralgia, but that's probably closer to the 5% range, I would guess.
What would you tell her about her vision? Because 9 out of 10 of these patients are going to say, what about my vision, doc?
It's a good question, and I don't have a perfect answer for you. I think that I would probably rely a little bit more on my ophthalmologic consultant and see if they could give me a little bit of a better idea of if there's any ability to recover any function there. I mean, if the retina
so the bottom line is you won't give her any kind of guarantees, or you would leave it sort of like, let's see what happens.
Yeah, I would leave it up in the air. I know.
Okay.
Yeah.
So how are you going to do this?
So, I mean, probably a ton of approaches to get to this area. The potential approaches, looking at, can you give me a sagittal?
I don't have a sagittal for you.
Or sagittal, okay. Well, going from an endoscopic approach, endonasal, would actually probably be a little bit more of a challenge in my mind, just because of the location of the optic nerve. Given where the optic nerve is, I think doing probably something more along the lines of a orbitozygomatic approach would allow me to take off the roof of the orbit, take off enough that I can relax the temporal lobe and access a majority of this tumor for debulking purposes.
Now, when you say an FTO, you take talking about an FTOZ?
Yeah.
You're taking off the whole zygoma?
You don't really need the zygoma for this approach, I don't think.
So what I would call an orbital cranial. So you take off the lateral orbital rim, sort of, and the orbital roof with the okay. Any other options?
You could do a lateral orbitotomy, but your lateral rectus may be a little bit more in the way or in the view. Potentially, I know some people have talked about doing like a transpalpebral approach or sort of a transorbital approach. I know that was discussed by people at Pittsburgh, but that may be more of a reach. Not something I'm necessarily comfortable with, so probably not the one I would choose.
Okay, so final answer time. What are you going to do?
Perional with orbitotomy.
Perional with an orbitotomy, so an OZ without the full zygoma off, and with the goal of decompression of the orbit. Correct?
Yep.
All right. So moving on to the next phase. This is yet another Magritte. Who is behind that apple? This painting is called La Fille de l'Homme, and another masterpiece of Magritte. And so we do have a surprise guest for you, someone behind the apple. The person behind the apple is none other than Professor Ted Schwartz. And I had briefly run this case over with him, and he said that he might have an alternative opinion to what Kunal just said. And I wanted to just give the floor to him for a couple of words. Professor Schwartz, if you don't mind gracing us with your opinions on this case.
Walter, thank you so much for asking me to participate. I feel like I'm on The Price is Right, where it's like, who's behind door number one? Look, I think that all the points that were made previously were really valuable and useful and thoughtful. And it's always hard to be put on the spot in these kinds of situations. I did get a chance to look at the films beforehand and had a few thoughts that I thought I might share. The first thought was, when you think about doing the endonasal approach, when you look at that axial view, that optic nerve looks very scary because it looks like it's medial and it's going to be in your way. But when I looked at the coronal view, although the optic nerve is medial, it's also very superior.
Right.
And so if you're coming in from below, it looks like there's a very large corridor that you can go through if you're lateral to the carotid and inferior to the optic nerve. You're going to have that space that you can go through to access the front door to Meckel's cave. And I do think that you could do this fairly well with an endonasal approach coming in from below from that angle. And it's all about thinking about the angle of approach. The limitations of the endonasal approach that I've found for Meckel's cave schwannomas is really when they go far into the posterior fossa. I think it's very challenging because you kind of have to go around that corner because you're working sort of laterally, and then you have to make a turn to go into the posterior fossa, and that's where I've left some tumor behind. So I think this would be a reasonable endonasal case, and I think that you'd be able to get the whole tumor out to a reasonable degree of certainty without a significant CSF leak.
And Ted, what are your thoughts about the carotid position? It seems to me like I don't do nearly as much endonasal cases as you do, but this is entirely in front of the carotid, which is kind of advantageous, no?
Yeah, it is. I agree with you 100%. I don't think the carotid is going to be in your way. I mean, even if you look at the axial on the far left there, you'll see that the tumor, the whole medial border of the tumor along almost its entire length presents itself into the sphenoid sinus. And so all of that can be opened up in excess to debulk the tumor, and the carotid is going to be behind you. And then, the siphon will come up and be, as you go higher, will be there, but you're going to be lateral to that, and mostly, for the most part, below the siphon to get this out. So I agree with you as well. Now, that being said, a couple of years ago, I was invited to Korea, and Doo-Sik was kind enough to invite me to a conference there. And I saw the work that he was doing, which I had seen before, and was really blown away by the transpalpebral approach and using the orbit, moving the orbit from lateral to medial, and using that corridor, drilling out the sphenoid bone to take out these tumors. And I started doing it that way. And I've had the opportunity to do a few of these cases using that approach. And you can do it with or without removal of the lateral orbital rim. It depends on your comfort level, how much room you need and feel comfortable. But I would do this case that way. I do think it's a great approach for these tumors. I know he's going to be talking about that, I guess, and he's really the master of that approach. But I learned a lot from him about that. And, if you look at the long axis of this tumor, which is what he talks about, and I think it's very true, the long axis of this tumor goes right along that approach that you get when you're medial to the sphenoid bone, lateral to the orbit, going right parallel to the lateral rectus muscle down the orbit. And there's not that much sphenoid bone you have to drill out. There's very little temporal lobe retraction, and it really gives you a great approach for a tumor like this. So I would actually favor that approach, even though I do think you can do this endonasally. I think ultimately the perspective that you get and the exposure that you get is slightly better, particularly that very anterior margin of the tumor. When you look in the second axial, it does go pretty anteriorly, pushing that optic nerve over, and very anteriorly. You may be easier to get to that. That's the first thing you're going to get to when you go through the eyelid.
So to summarize, even though you think that this can be done endonasally,
Yeah.
you would actually do the transorbital.
Yeah, I probably would. Although I think you'll get a gross total resection either way. I think you'll have a good outcome either way. I don't think there's a wrong answer. Look, there's a lot of right answers, right? You can come subtemporal and take this out. You can do it
right.
and take this out. So, but I like doing minimally invasive approaches when I can. And I think patients do better when you can use a minimally invasive, minimal access approach. So I would favor one of those two.
So Ted, I know you have to rush off to the OR, so thank you so much for those couple of thoughts and being our surprise guest for the day.
Yeah, my pleasure.
And again, we'll have you for a full session very soon. So so I'm going to give you all my thoughts on this before Diego, and this is just to really make Kunal feel a little bit better, because at the end of the day, we all have to do things that we're comfortable with. And to be honest with you, I haven't done the transorbital case, and I would feel a little bit uncomfortable doing a big case like this is the first one. You obviously have to get comfortable with it in the lab first. So to be honest with you, I would probably go transciliary and make a supraorbital keyhole, and then do orbitotomy and maybe anterior clinodectomy to get to this. I probably won't do a OZ, although that would have probably been my go-to about 5 years ago. So it's a minimal invasive approach, superciliary, transciliary, supraorbital keyhole with orbitotomy on this. Now, I think Diego's probably done something different, and he's going to show us his mastery right now. So Diego, let's, Dr. Mendez will be our presenter. Go ahead.
Yes. Well, thank you very much for the different opinions. I considered that in this case, we had several limitations as it has been discussed. I considered one, that the optic nerve was medial to the tumor, and that it would limit my resection in case I went through an endoscopic approach. Even though it seemed to be cystic in multiple compartments, you never know the consistency of the tumor. And so I didn't want to consider working with the carotid medially, and I didn't want to consider to have the cranial nerves also, even though she is not with a functional visualization. So I didn't want to consider that medial to my approach. I wanted to see an approach that I would go laterally. And so I considered this. The anatomy of the cavernous sinus is so important for this kind of tumors. In this dissection, cadaveric dissection, we can see a peeling of the middle fossa with the exposure of the cavernous sinus, where you can see the V1, V2, V3. We can see the fourth nerve and the third nerve with the exposing carotid segment of the internal carotid artery. And so we are thinking that the tumor is going to be localized in this area with the opening of the superior orbital fissure. And considering this logic of the tumor, I'm thinking that with unroofing the orbit, I will have a full exposure of the tumor. And so it is very important to have the anatomic visualization of the case, even from the orbit. This is a cadaveric dissection, but I'm not considering to do obviously this. I'm considering that the tumor is going to preserve and be outside of the muscles, of the orbital muscles. So considering this anatomic thoughts, between these cases, I considered that it would be safer for my case to go with a peeling of the middle fossa through a terminal approach with a lateral orbitotomy. So this is my thought of the case prior from where I was expecting that the tumor would be located in this localization from the cavernous sinus, Meckel's cave cavernous sinus, and that the tumor is going to go through the superior orbital fissure to the orbit. So if the nerves are going to be medial to the tumor, I could open the lateral wall of the superior orbital fissure in order to expose the orbit. If the nerves were lateral to it, I could not open it because they're going to be on my way. So so for this, we went in positioning, the key surgical steps, the positioning, just the regular terminal approach. This is from a cadaveric from our lab. This is the exposure of a normal pterional approach with the dissection of the cutaneous flap. It's going to be reflected rostrally. We do an interfacial dissection and exposing the zygoma. We like to, in these cases, we like to take out the lower rim of the zygoma to take it in order to make the muscle come down. And
Oh, so you would do a zygomatic osteotomy to flip the temporalis down?
Just the root of the zygoma, yes. In order to
Just
have
the
a better, just the root, in order to have the muscle come down all the way down, so it doesn't obstruct my case. And so this is the pterional classical approach with the and this is, for me, this is the crucial step, because here we are unroofing the orbit. We are exposing the orbitomeningeal band, and this is the most important part in order to do a peeling of the middle fossa. Yes, exactly. We coagulate that orbitomeningeal band. We coagulate it, and it's very important to section it, to cut it sharply in the direction of the anterior clinar process. This is the classical way in order to do an extradural clinoidectomy, and to start once you cut the orbitomeningeal band in that direction, there's going to be a plane that comes exposed in order to do a peeling of the middle fossa. Yes. There we are cutting the orbitomeningeal band, and once it is cut, then you can, like in the next slide. Yes, now there's exposed the anterior clinar process, and as you can see, there's a small peeling, an opening of the superior orbital fissure. There we can see that the orbit was exposed, and when we have the anterior clinar process, it is very important to have an analysis and remember always in mind the anatomical concepts of the anterior clinar process. The anterior clinar process is going to be attached by it has three attachments: a lateral to the lesser wing, a medial to the optic canal, and to the optic strut. So it's very important when we are doing a cadaveric dissection, or like in this case, or in the OR, to always remember, for the trainees, always remember the three attaching points of the anterior clinar process. Okay, so this is, and so after this, we did the anterior clinoidectomy. We can see that we have the clinoidal segment of the carotid artery exposed here, and it is covered by a thin oculomotor carotid membrane that's going to be between the rings of the carotid. Then we can do a complete peeling of the middle fossa, and we have exposed the lateral wall of the cavernous sinus. This is the approach that in my mind, it's exposing the complete segment of the tumor in order to have a full exposure and not have any of the cranial nerves obstructing my view. So in this case, we did what we were expecting, what we are showing. We did the pterional approach. We pull down the muscle. Here we can see that there I'm opening the orbit. We are opening the orbit, and we are opening the superior orbitary fissure at this point. We are drilling the orbit. There we can see that we have exposed we are coagulating the orbitomeningeal band, and we are cutting the orbitomeningeal band, and there we have the anterior clinar process exposed. Once we have exposed, we can see that we have exposed the tumor, and this is the insert of the cadaveric dissection that we were talking about. And at this moment that we have the complete middle fossa open, we have the complete exposure of the tumor as we were expecting, as we were thinking and expecting and discussed earlier. There, I do a thorough analysis to see if I don't see any of the branches of the any of the cranial nerves. I open of what I would expose to be the Parkinson's triangle, and I can see that there's free space in order to open all the way to the orbit, as it is shown in this moment. And there I am opening through the superior orbital fissure. And as I was saying, always remember, and always very important to have in mind, the anatomy when you are doing the surgery. It's always coming back to the anatomic concepts of your dissection. Even though if you have navigation or any other tool, it's always the anatomy that's gonna lead your dissection. And so at this moment, I can see that the consistency of the tumor is favorable. And so I start dissecting part of the tumor, and we can see that you can remove freely and it's suctionable. And then at this point, we are inside the cavernous sinus, and we are removing all the tumor. There we are using the microdoppler in order that we have exposed the cavernous segment of the carotid artery. And at this point, the cavernous sinus is completely opened by the tumor. The tumor led us to the lesion. Okay, this is the pre-op and this is the post-op. And in the next slide, the patient, she didn't have any problems with the eye movements. The issue about any recovery of the visual function, she said that she recovered and it was not trustful, it was not functionable. She said that she could see some how do you call it, to see the
Shadows,
hand movement.
maybe? Yeah, okay. Yeah.
Shadows, exactly, shadows. And but in a way it's not functionable. And but this is the clinical outcome. She's been 8 months after it and still with the shadows supposedly, but it's not very trustful in the exam. Okay.
But you were able to save the third nerve, which is very important cosmetically.
Yes,
so at least she can have an eye open. She doesn't look like she's like with one eye there. You know, it's very important for us for me to admit that I'm wrong. I think that, in fact, I would, now that I notice how low that tumor goes, I would revise my answer. I think Kunal did better than I did. I gave a wrong answer. I probably would not do a transciliary and supraorbital keyhole. It's really the mini-pterional keyhole that would work for this much better because of how low in the middle fossa this is. Dr. Mendez, masterful surgery as always, and a great discussion of the anatomy, and thank you so much for that. So now we turn our podium. I'm going to stop sharing my screen for a second. We're going to turn the podium to Dr. Doo-Sik Kong, who is an expert in this anatomical territory and has some very innovative ideas, which a lot of us are not very comfortable with yet, but perhaps in the future will be. So Doo-Sik, please share your screen, and the podium is yours.
Yes. How are you, everyone?
Great.
And can you see my slide?
We can see your slides, but yeah, go. Yeah, perfect. Now we're good.
Yeah. I'm Doo-Sik Kong from Samsung Medical Center, Seoul, Korea. So first, it's great honor for me to be invited to this wonderful webinar. So I'm going to talk about the endoscopic transorbital surgery for macroscopic and cavernous sinus tumors. First, I would like to talk about the surgical corridor of transorbital approaches. Before my presentations, maybe this case may be very similar to the Diego's case series. The tumor mass involved cavernous sinus and originating from the V1 tumors embedding into the orbit. The patient complained of long time history of the proptosis and blood visions and facial numbness on the right side. Before my presentations, I will talk about the endoscopic transorbital approaches. Trigeminal Schwannoma mainly involved the middle cranial fossa. Some tumors are extending to the posterior cranial fossa, and sometimes the B1 and B2 and B3 extending the tumor. The long axis of these tumors from the lateral to medial and from the anterior to the posterior side. So I thought that the optimal surgical approaches should be in line with the long axis of the tumors, as the TED already described it. And also, this is a trigeminal Schwannoma cases involving middle cranial fossa and posterior cranial fossa. Some neurosurgeons favor FTOG or anterior pituitary approaches. Other neurosurgeons favor the posterior pituitaries and the retrosigmoid approach according to their experience. Instead of these conventional approaches, some endoscopic neurosurgeons favor the endoscopic endonasal approaches. But I think endonasal approaches has some limitations because it has crossover the optic nerve and also it crossover the ICA. So some cases, some tumors, most anterior part of the tumor or most the posterior cranial fossa tumors or superolateral portion of tumors can be left. Instead of that, I suggest endoscopic transorbital approaches can avoid to face the ICA, and it goes through the lateral portion of the cavernous sinus. It's almost the same as FTOGs, but this is a minimal access tumor. In the previous papers, I showed that transorbital approaches provide direct view and short distance compared to the endonasal approaches, and also transorbital approaches can spare the medial nerve. Cosmetically, it has good, excellent cosmesis. It leaves less and minimal scar. It can reduce hospitalizations and limited morbidities. And also it has no need of brain tractions, no post-op headache, no venous related injury. Let's talk about lateral orbitotomy. And some surgeons favor the lazy as incisions, but because of the wound problems, I don't favor it. And for me, I prefer the superior eyelid crease incisions or supraciliary incisions. Sometimes we combine the lateral cancer incisions combined with the inferior transconjunctival approaches. I'll show the details later. And let's talk about anatomy of the orbit. And this is the orbital anatomy. The most important structure is very simple. Only orbicularis oculi muscles, levator aponeurosis, and orbital septum. We inside the skin along the superior eyelid crease, and then cross-sectional image shows that we divide the orbicularis oculi muscles into two pieces, and then we have to reach the periosteum. We have to be careful about not to injure the orbital septum and levator aponeurosis. If so, the patient may experience a postoperative ptosis. And here, the most important thing is our final target is periosteums, not the superior orbital rim, but the lateral orbital rim periosteum. Because lateral orbital rim is very near the skin incisions, very easily accessible, is very near. So I thought that lateral orbital rim exposure is very important and very easy technique. For example, after skin incisions, we divide the orbicularis oculi muscles, we expose the orbital septum here. Then our final target is periosteum on the lateral orbital rim, not superior orbital rim, because relatively this is the longer distance. So after exposing the orbital septum, our dissection direction is not here. Direction of the dissection is here. So we first expose the lateral orbital rim, then we can extend to the superiorly as necessary. And then inside the periosteum and superiorly extended and then elevate the periosteum and periorbital. Sometimes the lateral orbital rim osteotomy may be very helpful to obtain the working space, especially for spinoorbital meningioma cases, but most macular cavum tumor and cavernous sinus tumor is located at the medial of the temporal lobe. So I do not recommend lateral orbital rim osteotomy anymore for cavernous sinus tumors. And next important landmark is the superiorbital fissures. And we have to identify the superiorbital fissure and open the lateral border of the superiorbital fissure. It's a very good indication, landmark. And then we have to drill the lateral to the medial side of the greater sphenoidal ring. We first expose the temporalis muscle, then the medially gradually debulk the mass, and then we could expose the anterior part of temporal dura, meningoorbital band, as Diego described, and also at the same time we could expose the periorbital.
So Doo-Sik, what is that? You're showing is that a retractor or a protector on the lateral side of the cone?
Yeah, so I will show my videos. But at first phase, and we need the spatular retractions, temporarily hand-held retractions. But if we go into the deep side, we don't have to use the rigid retractor. Only with the suctions we can push the eyeball. Yep. And then we could fully expose the temporal dura and meningoorbital band and periorbital area. Then we can expect the pathway of the trigeminal nerve. According to the tumor locations, and we can select the optimal triangle, anteromedial, anterolateral, or posterolateral triangle. As you see, they would describe that one. So using the interdural dissections with the peel-off techniques, we could differentiate the dura propria from the temporal lobe, from the outer membrane of the cavernous sinus. Then the tumor involving here, we just opened this tumor. And then when we enter the cavernous sinus, then we could identify the V1, V2, and V3 area. And you can find the gastric ganglions. And these are our series and published in the papers about the transorbital approaches for macular cavum and cranial fossa tumors. Trigeminal Schwannoma can be classified into multiple types. I thought that transorbital approach is very good for the V1 origin tumor or V3 origin tumor, and middle cranial fossa tumor, and middle and posterior cranial fossa tumors is still challenging for transorbital approaches. But posterior cranial fossa tumors, I don't recommend transorbital approaches until now. I recommend posterior approaches or other, such as retrosigmoid or posterior pterygoid approaches. Then I'll talk about my case series. This is a very simple cases. The 25-year-old man complained of hyperphagia on the face on the right side 2 years ago. The mass involving the large system mass mainly involved the middle cranial fossa and extending to the posterior fossa. I selected the transorbital approaches here. Then we can avoid the ICA. After injection of local anesthesia, we inside the skin around the superior eyelid. Then we would expose the orbicularis muscle here. This is orbital septum. Then our final target is lateral orbital rim. We don't have to approach the superiorly. Periosteum is a very hard bone, and then we can easily, safely dissect the lateral, periosteum and more superiorly here. Then we elevated the periorbital and periosteums more medially. Then we identified the superiorbital fissure. In this case, it's my early experience of trigeminal Schwannoma. At that time, I removed the lateral orbital rim to obtain the working space. And already I removed the lateral orbital rim. We exposed the temporalis muscle. This is greater sphenoidal ring. This is the superior orbital fissures medially. Then we drill the greater sphenoidal ring here. Then here, this is a lesser sphenoidal wing. I drew the greater and lesser sphenoidal wing. Oh, I'm sorry, slide, skip it. And then this is the cavernous sinus here, subtumor, and I try to dissect the tumor capsules from the trigeminal fascicles. Then this is the middle fossa tumor capsules. I dissected from the posterior capsules here. Then I remove the tumor capsules within the cavernous sinus. Then this is the outlet to the posterior fossa. You can find some anterior surface of brainstem. And then maybe this is a gastric ganglion. I try to dissect the tumor capsules from the gastric ganglion. Finally, I remove the posterior capsules. And this is the space within the cavernous sinus. And then relatively large space, you can find that one. To close the posterior outlet, I close the duragen for the outlet to the posterior fossa. And then to obstruct the inlet to the cavernous sinus, I place the fascia lata with the multi button layer techniques. And then finally, to avoid anophthalmos, I placed Medpro plate as recommended by my oculoplastic surgeons. And then we close the skin with the 6-0 nylon sutures. Postoperatively, all tumors are removed and the immediate postoperative patient images. This is another case, it's a very similar cases, mainly involving the middle cranial fossa. Yeah, as my experience accumulates, the operation time was shorter, getting shorter. We expose the orbital septum and then incision of periosteums on the lateral orbital rim, then extend to the superior part. In these cases, I did not remove the lateral orbital rim. Then we expose the lateral orbital wall, from lateral to medial side drilling. And drilling of the inferior part of greater sphenoidal wing is very important. Then I dissect the meningoorbital band. Maybe this is V1, maybe V2 space, a V2 pathway. We fully expose the V1, V2 space. Then we trace this side is V2 space. Then we remove. After removal of the tumors, we can find the V2 and V3. And maybe some tumors are left along the V1 areas. After removal of the tumor, we can find the posterior outlet to the posterior fossa. The same technique was closed. Closed technique was almost the same with the taco shear or duragens. And finally, we closed with the fascia lata, placed the Medpro, and we close it. Postoperatively, all tumors are removed within the cavernous sinus. This is another case, it's V1 hyperplasia, as I will skip it. Some tumors are extending to the posterior fossa. It's almost the same on incisions. I will show this part. Yeah. When we approaching the supraorbital fissure, maybe recurrent meningeal artery is a very good indication because this artery was in front of the supraorbital fissure. Inferiorly, you can find the zygomatic facial arteries. You can easily coagulate. This is the bone maxillary strut occupying the B1 between the B1 and B2 space. Is removal of maxillary strut is very important. And you can find that this is V2 here. V2 nerve. Maybe we found the third nerve. Very careful, not injured this one. This is the outlet to the posterior fossa. Yeah. Maybe V1. V2 already injured by the surgery. I thought that I skip it. And this patient is the left side is operation site, so all tumors are removed. This patient is a very unique case, mainly involving the V3 origin tumors, involving the intracranial fossa. In these cases, I performed inferior transconjunctival incisions combined with the lateral cancer approaches. Collaborating with my oculoplastic surgeons, then we can easily access the inferior part of the orbit areas. But we have to expose the greater sphenoidal wing, then drill the same technique. Incidentally, we open the sphenoid sinus medially. Maybe this is the foramen rotundum. And then the tumor is located at the V2 and V3 areas. We drill the more flattening of the base of the orbit area. We routinely open the meningoorbital band to obtain the working space. This is V2 and V3 space. Then we dissect the tumor with the arachnoid knife. These tumors involving the middle and infratemporal fossa areas. Same surgical technique was applied. Tumor was very thick and adhesive to the surrounding tissues. Angled grasping forceps can be very helpful to remove the tumor. Finally, you can find the V2 nerve. Here, after removal of the tumor, you see that there is no tumor left within the cavernous sinus and infratemporal fossa areas. The advantage of transorbital approaches over endonasal approaches, you don't have to manipulate the pterygoid muscles, lateral to and medial pterygoid muscle, and also we can avoid the medial nerve injuries. Postoperatively, 4 tumors were removed. And this is my first cases. The tumor involving the orbit areas, it's the same technique. Maybe this was my first case of trigeminal Schwannoma. So we already removed the lateral orbital ring. Then the quality of the video is not good, but it's the same techniques. Lateral to medial side drilling of the greater sphenoidal wing, same technique. Then this is the meningoorbital band. We open the meningoorbital band. You can find the tumor capsules from the cavernous sinus embedding into the orbit areas. The most advantage of transorbital approaches, it can expose the middle cranial fossa and also orbit areas at the same time. So we removed that one. Internal debulking, capsules. So we first removed the cavernous sinus tumors, and finally, I opened the periorbital, and then the lateral part of the tumor was removed. This is within the cavernous sinus here. And maybe I skip it. Yeah, this is the orbital part of the tumor. I removed it, and some pupil size was dilated. I closed it. Immediately, the patient had a complete ptosis, but fortunately, the tumor was completely removed. And at the follow-up of the 1 year post-op period, the ptosis was relieved.
Now, for this case specifically, Doo-Sik, I think if you knew that the tumor was really hard and the consistency is really, really firm,
yeah,
you might consider something else, right? Because I think you were significantly aided by the tumor being a soft tumor. You can get around the capsule. Am I correct in assuming that?
Yeah, and then actually this tumor is relatively hard compared to the other Schwannoma masses, but the same surgical technique after internal debulking.
I see, the debulking helped you with that.
Tumor capsulations capsular dissections and then grab it in. The same technique was applied. And then for among my 65 cases of transorbital approaches, I experienced some complications, 2 cases of wound infections, cellulitis, 3 cases CSF bleed. Every case was meningioma cases because meningioma cases leaves a huge defect of dural, but all patients were treated with lumbar drainage, not requiring the revision surgeries, and experience of 1 case of endophthalmos after operations. But in this case was the traumatic cases, and we combined with the endonasal and endoscopic transorbital approaches, whole orbital wall was defect. And I experienced 1 case of ptosis, complete ptosis, because the tumor origin was oculomotor Schwannoma cases. Still, so we are now observing it. Let me talk, this is almost the final slide, how to reconstruct the transorbital approaches. And I first recommend use the Dragen or taco seal to close the outlet to the posterior fossa. And also, I graft fascia lata or allodermis for inlet to the cavernous sinus. And also, fat graft or lumbar drainage can be optional for meningioma cases. For example, spinoorbital meningioma cases. But for Schwannoma cases, I do not recommend fat graft and lumbar drainages. And finally, we place the Bedford plate to avoid endophthalmos, and 6-0 nylon sutures for skin closure is important to minimize wound infections. And also, this is my final slide. Endoscopic transorbital approach is still alternative the surgical technique. So I thought that more studies and larger case series are needed to validate these techniques. Thank you.
Well, masterful work, Doo-Sik. That's very, very impressive. I've known Dr. Huang for a long time now, and on and off, I've been looking at his facial expression when you're talking, and I can see that he's looking at this going, oh my God, this is just awesome. And it is an awesome, a couple of really practical questions, Doo-Sik, if you don't mind. So you had the handheld retractor on the globe retracting a little bit medially first. Does that assistant then leave that, or is that blade in there for most of the resection too? Yeah,
the retraction duration is very important. My oculoplastic surgeon recommend in my first experience of transorbital approaches, and maybe temporary handheld retractor, and for maximum 10 minutes, and then release the orbit, and we have to intermittent check the pupil size. 2 long-standing retractions can develop the pupil size dilatations and oculomotor palsies or the blood pressure changes.
So for your long cases where you're doing the schwannomas, is the assistant intermittently taking the retractor out and in?
Only through the greater sphenoidal wing.
Only when you're drilling the sphenoid wing. Yeah. When you're resecting,
after drilling of the greater sphenoidal wing, we don't have to the retractor orbit.
Okay, so that's gone. Okay. The next question is another practical question. Your endoscope is held by an arm or a person, or who is holding the endoscope?
As my fellow holding the endoscope, but nowadays I use the pneumatic arm or the Mitaka holder.
So you use Mitaka arm, okay. Yeah, but the Mitaka arm is coming superiorly to the resecting surgeon. The surgeon is more inferior to the endoscope. Is that correct?
Yeah, right. Okay. So I use this one. It's very narrow space.
You know, I'm old enough to remember when Ricardo Corral and Haedong Zhou and Amin Kassam started doing the endonasal approaches, and initially everybody thought that, wow, this is really awesome, but let's wait to see how the complications shake out before we jump on board. And lo and behold, now everybody's doing endonasal endoscopic cases, and I have a feeling that this is going to be the next wave. And kudos to you, Dr. Kong, for the innovation and being part of the innovation team on these sort of approaches, and for all the young audiences around the world watching this, I hope that this intrigues you and you go to masters like Dr. Kong and learn these techniques, because this will be, I think it's here to stay, and it will be moving forward a very useful technique to have in your tool bag moving forward. I'm going to go around the panelists and ask them for their opinion on this. Kunal, did you do any transorbital cases when you were in residency?
Not with an endoscope, and not quite like this. This was
so as a young surgeon, still learning, if you will, as a fellow. Do you think, what is your view on this? Is this very radical? Is this something that young people like yourself should learn? Where do you think?
So I would say initially I thought this was a pretty radical approach for such a large tumor, and something that I would typically have a lot more exposure for. But after looking at the amount of exposure he had, and more along the lines of the idea that he had that you want to operate down the long axis, I think it actually makes a lot of sense. My biggest challenge with this compared to adopting endonasal approaches is, with an endonasal approach, there's less that I'm worried about injuring that's not immediately in my field. And my biggest concern with this is monitoring intraocular pressure, or kind of getting a sense of working near the orbit. And I think that's just the fear or the hiccup that I need to get over before I really think about this.
But that's the same sort of trepidation at the beginning of the endonasal revolution, if you will. Everybody's talking about the nasal mucosa getting injured. CSF leak was a big topic of discussion, that, oh, then we will never be able to solve that. And then the nasal septal flap came around and everybody jumped on board. So we might be seeing some sort of similar thing.
Yeah.
Dr. Mendez, you're about my age, I would think. How would you compare this revolutionary step to what we learned in the endonasal era? What do you think about the transorbital approaches?
Well, I think it's very interesting. I think that as we were saying earlier in the week, all the armamentarium that we can get in order to specific cases, it's very important. There are a few things it came into my mind while I was seeing the wonderful presentation of Doo-Sik. It's about the movements, how I felt it was a small, like the free movements, one thing. The second thing is safety, like in case you get a lesion, an arterial lesion from a branch of the ICA or by the ICA, what do you do in such a small space? The CSF leak he was mentioning, and mostly the consistency of the tumor or the pathology is like if it's favorable or not in order for the correct approach. Anyway, I think it's a good thing to have a wide view of different way of doing things, but you have to analyze all those things, mostly for trainees or people that are starting. Doo-Sik, he has a great experience with more than 60 cases, but I think that all those things are helpful to be considered whenever deciding to do one of these cases. In my case, I like to have everything exposed in order to have free movements and to maneuver in a good way the pathology, and not surprises,
But how does that differ from your endonasal approaches? I mean, I know you do plenty of masterful endonasal work. So how is that different? That also is a narrow corridor.
Yeah, definitely. I feel well when you are removing the orbital, the sphenoid wing, I think he had more movements. It's similar to the endonasal, that you have when you don't have an speculum of the transeptal, you have now free movements in the endoscopic. Okay, but I don't know. It would be interesting to try it in a cadaveric dissection first, in order to try it and to see how good the movements are, to get accustomed to the anatomy in this other perspective. It's also important. So it's something that we should definitely gotta try it in the cadaver, in the lab first.
So Doo-Sik, let me ask you that. I mean, great questions raised by Dr. Mendez here. What about, have you encountered any vascular excitement, shall we say, during any middle of the transorbital cases?
For what do you mean, the vascular case?
Injury to the vascular that you know becomes a very scary moment.
As fortunately, I never experienced the vascular injury.
Because vascular.
Yeah, transorbital approaches go through the lateral part of cavernous sinus. Only cavernous bleedings can develop, but we can easily control with the flow series. But actually, I don't have any experience of ICA, but I'm still care about in the future, in the near futures.
Okay, and a follow-up question. Are there tumors in the same location, in similar locations, where you look at scan and say, oh, I'm not going to do this transorbital because of the consistency of the tumor or some other features that would say, oh, no, this one is an open case?
Yes, for my early experience, the spinoorbital meningiomas can spread into the lateral part of temporal lobe and spreading into the frontal lobe and even into the embedding into the infratemporal fossa areas. So I tried to remove the infratemporal fossa areas, but meningioma is very hard consistencies or sometimes atypical findings, and then there are many limitations. So the only meningioma case, meningioma size is limited within the 4 centimeters, not spreading into the dural, and such as the Schwannoma cases or dermoid cyst, it's a sarcophagus cases. But I don't recommend the wide extensive the meningioma cases.
Okay, so big meningiomas that especially you think it may be a heart. Just for the, I'm going to share my screen once again for one moment. Just for the younger audience, I made a little cartoon with my virtual reality tool to show hopefully what could be interesting. So, you know, we can skip this. We're going to play this. So I put on the virtual reality machine 3 targets at the orbital apex: the green, the red, and the blue dot. One's north, one's lateral, and one's medial. And you can see that, you know, perhaps we really should have all the tools in our tool bags. This is your transorbital approach done through virtual reality, drilling the greater wing of the sphenoid back towards the superior orbital fissure. Now the superior orbital fissure is getting close, and you can see how close you are to that red target that's lateral to the globe there. The pink, by the way, is a trigeminal nerve in the background. They're covered, of course, by temporal lobe in real life. So if you look at this target from an inside-out point of view, you will see that it actually is right lateral to the superior orbital fissure, and you have a really good shot of that going transorbital. Now, the green dot is going to be next. You're doing septotomy, sphenoidectomy, and then really when you do a full sphenoidectomy and you find the OCRs right there, you can just follow that optic nerve out, and you see, I mean, you can almost see that green dot already, but that green target is really right there for the taking. So that's the medial target of the orbital apex. Now, for the blue dot, which is at the superior edge of the orbital apex, or superior pole of the orbital apex, maybe this sort of transciliary supraorbital keyhole could be very useful. You drill down the optic orbital roof, and that blue dot is right there. So this is just to show that, you know, we really need all the tools in the tool bags, and obviously the tools can be used in combination if the tumor kind of spreads and straddles those zones. So hopefully that gives everybody some sort of schematic view on that. For different targets, there might be different ideal, so-called ideal approaches. Dr. Wong, any final thoughts before we leave this wonderful session?
Yeah, no, this has been an amazing session. I think it really highlights how just changing your perspective from intracranial to extracranial, looking down different axes of the tumor can guide you as to what kind of a best approach. And as you said, you really need all the different tools. And also, I think, you know, as somebody who's sort of still early but middle part of a career, you do start to realize that as you're working on these types of tumors, that at first you seem like a a wide exposure may be the most optimal, but ultimately you're coned down to where the tumor is, and you're working, even under the microscope in a very small space. So I think having these, all these different tools and different ideas is really important. And I think for the trainees, I think one theme that has been shown here is these are, when you develop these, when you first learn these, you start out in the lab and you gain experience sort of in the basic science of skull-base surgery, which is anatomy, before then you're moving on and practicing in a real case. So I think that learning curve is also very important to appreciate.
I'll certainly second all of that. I want to address another one of Diego's questions. This is going to sound like a promotion here. We just submitted a paper to ACTA about the areas of freedom, comparing the supraorbital keyhole, the mini-pterional keyhole, and the translateral orbital wall approach. It's more Dr. Caldwell's, what he has written, not an endoscopic, leaving the lateral rim kind of approach, but the transorbital approach really is unbelievably direct to the maxillary strut and the foramen rotundum area. Having said that, however, the areas of freedom, when we measured it, is significantly smaller than what we're used to with the mini-pterional or supraorbital keyhole. So hopefully ACTA will do something good with that paper. Any questions from the audience? I see that there are not a lot of Q&As. Mike, any thoughts?
So the one question here that was is maybe worth discussing is the consideration of radiosurgery for lesions in this region.
Well, it's certainly, I mean, what radiosurgery does really from my point of view is that it makes us really better surgeons, because the stakes are a lot higher. If you're not able to take out the tumor, you certainly don't want to hurt the patient taking that last piece out, because there is a fallback plan of doing radiosurgery. That's really what, for me at least. Dr. Mendez, your thoughts on radiosurgery? I think you're muted, Diego.
Yes, definitely. I agree. It's also another tool, and it's always to play safe, to play on the safe side of the surgery. So if it's radiosurgery is for a residual that you can observe, and if it grows, you can radiate it if it's required. I was thinking. For example, for trainees, like for a message, I would like to ask Doo-Sik his previous experience. How did he do it? Because right now he's a very experienced surgeon, but for trainees, like in order to start with one of these approaches, I'm not sure if it's the best thing. I would like to ask Doo-Sik if I guess that he did it previously in some other approach, and after some time he developed this narrow corridor. But I mean, like, I think that for trainees it's very important to have, like you said, all the different tools from different approaches and develop with experience into a more narrow corridor. I would like to ask Doo-Sik if how he did it prior to this approach.
Yeah, how did you get into it, Doo-Sik? How did you develop this?
So I believe that the transcranial approach is very familiar with neurosurgeons, but transorbital approaches, the anatomy is very unfamiliar with us. So I don't recommend for these transorbital approaches for beginners. After mastering the transcranial approaches, and then we can move to the endoscopic approaches. And also, at the same time, I believe endoscopic endonasal approach is also very important, because we need to manipulate our equipment under the narrow space. Is almost the same as the transorbital approaches. So we need to step by step we can expand our cities.
So Doo-Sik, are you taking fellows? When can I join?
Thank you.
But are you taking fellows? Are you actively training a lot of young surgeons to do what you do?
I'm sorry.
Are you taking students? Are you taking fellows?
Oh, sure.
You have fellows that train,
Yeah.
and that's what the young audience need to hear about. That if this excites you, you should go to masters and learn all this. We are over our time for this webinar, and I would really sincerely thank everybody who participated today, including Dr. Schwartz, who's run off now, Kunal, Doo-Sik, and Diego. This has been an amazing session because there's so many options to that one particular tumor. And to thank you, Diego, for bringing that tumor to the table to start as fodder for this vibrant and multifaceted discussion. I'm worried about the next session. The next session is going to be in 2 weeks on the 23rd of July, and we will have a brand new case for you with experts from Boston and Bogota. So I thank you for our audience for being with us, and I thank all the experts for being part of the panel, and I bid you have a good day. And have a good night, Doo-Sik.
Have a good night.
All right, bye-bye.
Thanks, Dr. Gene.
Thank you very much. Bye-bye.
Thank you.